Hello and welcome to the California Cancer Caucus virtual legislative briefing on biomarker testing, the future of patient care and improved outcomes. My name is Hilary Gee Goeckner. I'm Director of State and Local Campaigns with the American Cancer Society Cancer Action Network, or ACS-CAN. I'm pleased to moderate today's briefing. The goal of the California Cancer Caucus is to develop a continuous line of communication and education between stakeholders and health policy decision makers as a resource for cancer-related public policy. A few housekeeping items before we begin. You'll notice on the bottom of the screen, you'll see a horizontal toolbar where you can mute and unmute and turn video on and off, as well as submit questions in the chat box. We're going to save questions for the end of the briefing, and please keep your line muted to reduce background noise. Before we get to our fantastic speakers, some quick background. Biomarker testing is an exciting issue, allowing doctors to better understand and treat individual patients based on the markers in their cells and tissues. Biomarker-informed treatments have helped reduce cancer deaths and improve quality of life. And beyond cancer care, there are a growing number of applications for other disease areas too. We have some great speakers lined up today to talk more about this important topic and how California lawmakers can help more patients benefit from the latest advances in treatment. First, I'm pleased to announce our first speaker, Senator Monique Limón, as the author of SB 496, to give an overview of her bill to expand insurance coverage of biomarker testing and talk about why this legislation is so important. Senator Limón. Apologies, we have a slight delay with Senator Limón, so I'd like to instead introduce Dr. Isla Garraway, a urologist at UCLA and the Greater Los Angeles VA Medical Center. She's also a research scientist at the UCLA Johnson Comprehensive Cancer Center. She's going to talk about the importance of equal access to biomarker testing, and we'll come back to Senator Limón later in the presentation. So with that, Dr. Garraway, the floor is yours.
Thank you so much, excuse me. Thank you so much, Hilary, and good morning to everyone. I'm really honored to be here this morning. Thank you so much to Senator Limón for leading this effort to raise awareness surrounding the importance of biomarker testing so that life-prolonging precision medical treatments can be accessible to all Californians. And thank you also to the California Cancer Caucus and the University of California for inviting me here today as a speaker. I am so grateful to have this opportunity to highlight why equal access to biomarker testing is such an important goal for our communities here in California. So I'd like to share a couple of slides. Let me try to get these up here. Okay, so hopefully you can all see my screen. All right, so again, my name is Isla Garraway and I'm a professor of urology at UCLA. And although I am here as a subject matter expert and basically regarding the role of biomarker testing in personalized cancer care, I am also someone who once really yearned and prayed for the tools that are available to doctors and patients today. So I found my way to precision oncology after my father, Michael, who is shown here with me on my wedding day 26 years ago, was diagnosed with the most aggressive form of prostate cancer. Now, this was 1997, and unfortunately, no precision treatments for prostate cancer existed at that time. If the biomarker testing and precision therapies were available to him then, he might have lived long enough to dance at my little sister's wedding or to meet his first grandchild. But over the course of 2 years, treatment after treatment failed. Some even had to be stopped due to debilitating side effects. In 1999, my dad was one of approximately 37,000 individuals to lose their battle with prostate cancer that year. And although thankfully that number is coming down each year because of many different things, but in part due to early detection strategies and new therapies, we still have a really long way to go. So inspired by my dad's journey, I became immersed in the medical research community and have witnessed firsthand the advancements in biology, drug development, technology, and clinical care which have led to the life-prolonging, biomarker-driven precision oncology therapies that are available today. Biomarker testing is critical now in my practice to detect and diagnose potentially life-threatening disease through screening and monitoring of my patient's blood, tissue, and other biospecimens. Biomarker testing helps doctors like me to decide which treatments are likely to work and which treatments likely won't work so that we can prioritize the best options for our patients. Biomarkers can also help determine individual and family risk of disease, since these markers can be inherited or passed down from one generation to the next. Therefore, it's possible to identify family members at the highest risk of developing the same condition affecting their loved one today, so that there is an opportunity for early detection and treatment that could be life-saving to them down the road. So finally, biomarker testing helps democratize medicine by identifying who may benefit from precision medicine approaches regardless of their residential zip code, their background, or their wealth, which brings me to the critical point of my message today. The only way to identify individuals who are candidates for precision medications and treatments is to make biomarker testing accessible. So again, to find the underlying molecular drivers of disease at the cellular or genetic level that can be matched to a specific targeted therapy, we like to call this approach finding the right drug for the right patient at the right time. We must perform biomarker testing on a patient's biological sample. So, for example, a patient who has been diagnosed with cancer may have their tumor analyzed for molecular characteristics to see if there is a targeted therapy available. Now, targeted therapies are different from standard chemotherapy treatments because they act on traits that are specific to an individual's tumor, sometimes encoded in that individual's DNA. So most standard chemotherapy agents do not require this type of testing for use because they're generalized kind of killing machines and can be tried in everyone based on the cancer type. But targeted therapies are often more preferable because they're more specific and then can be less toxic than the standard chemotherapy. And now in many cases, we are learning that they're also proving to be more effective than traditional chemotherapy treatments. So the bottom line is that timely access to appropriate biomarker testing can help achieve better outcomes, improve quality of life for our patients, and reduce the cost by reconnecting patients to the most effective treatments for their cancer. So what we do know, unfortunately, is that not all communities are benefiting equally from these advancements in biomarker testing and precision medicine. So it's very well known, as you can see from the data shown in the center of my screen, that racial and ethnic disparities are consistently evident across numerous cancer types. So compared to white men, cancer incidence in Black men is 6% higher, and cancer mortality is 19% higher in these individuals. And you can see that in the blue line with the triangles that floats so high above the other lines. The blue line is the African American population, and this is their rate of death, which is so much higher than other populations. Now, although Black women have an 8% lower cancer incidence compared to white women, they have a 12% higher mortality rate. There's also new published evidence that an individual's zip code, their zip code, is associated with the length of survival for a variety of different cancer types. So here is data showing overall survival of patients with prostate cancer based on their zip code. The top line includes zip codes representing neighborhoods in the top 20% of socioeconomic status. And then each subsequent line represents less wealthy neighborhoods until you get to the bottom line, which are the most socioeconomically deprived neighborhoods. So the trend is clear. The wealthier neighborhoods, the longer the survival. The poorer the neighborhood, the shorter the survival. Now, the reasons for these findings is likely multifactorial and include barriers to care, such as insurance and transportation. However, published studies of FDA-approved biomarker testing for precision medicine therapies have found that marginalized communities, including communities of color, individuals with lower socioeconomic status, and rural communities, and those receiving care in non-academic medical centers are less likely to receive biomarker testing. Therefore, improving coverage for and access to biomarker testing across insurance types could prove to be a critical factor in reducing health disparities. So we must be proactive and address the issue of biomarker testing so that existing disparities in cancer outcomes by race, ethnicity, income, and geography are not further exacerbated. Access to affordable care and insurance reimbursement for biomarker testing and precision medicine is important to make available to all California residents. This bill has the potential to be incredibly impactful in achieving this goal. So thank you for your attention and for your willingness to engage and learn more about biomarker testing and precision medicine and the importance of this initiative today. And I'll hand it back to Hilary. Thank you so much.
Great. Thank you so much, Dr. Garraway. That's a really fantastic background on why this matters so much, and a perfect segue into Senator Limón to talk a little bit about the legislation that she is sponsoring and why policy action on this issue is so important. So with that, Senator Limón, thank you so much for joining us.
Thank you, Hilary, and thank you to the California Cancer Caucus for convening this briefing on biomarker testing, the future of patient care and improved outcomes. I have been working on improving access to biomarker testing for the last 3 years. This is a topic that many, including myself, are familiar with, but my knowledge and understanding of biomarker testing has only grown, given me insight into what is possible for many patients that are looking for some type of medical hope. Precision medicine is improving patient outcomes by using their own genes or proteins as biomarkers to prevent, diagnose, and treat diseases. Biomarker testing can be performed for conditions such as prostate, ovarian, breast, and lung cancer, among others, in addition to Alzheimer's disease and rheumatoid arthritis, type 2 diabetes, and other conditions. Biomarker testing looks at patients' gene mutations to help match them to effective individualized treatments. And those are strategies that are very key and important to understanding the genetics of a patient and how we can improve survival rates and their quality of life. In 2021, I authored Senate Bill 535, which became law. The bill prohibits health plans from imposing prior authorization for biomarker testing in patients with advanced or metastatic stage 3 and 4 cancer. Subsequently, we learned that barriers to access and coverage of biomarker testing were broad and did not cover all circumstances that were applicable under SB 535. A 2021 survey of the American Cancer Society found that 66% of oncology providers reported that insurance coverage for biomarker testing is a barrier to biomarker testing. Therefore, last year, I authored a follow-up bill to expand coverage on biomarker testing for all patients. The bill establishes criteria and guidelines that must be followed to make coverage determinations for biomarker testing by health plans, health insurance policies, and Medi-Cal program. Unfortunately, the governor vetoed last year's bill, but I reintroduced a bill this year, Senate Bill 496. I'm hopeful that the governor will sign 496 into law, ensuring patients have access to the necessary treatment leading to better quality of life. I'm also hopeful that as advances occur in biomarker testing, more patients with a variety of conditions will benefit from the availability of emerging biomarker testing. Access to appropriate therapy and care is really personal to me, as I've had loved ones in my life who have benefited from biomarker testing. Thank you for being here to learn more about biomarker testing and the benefits that it has to patients and families.
Thank you so much, Senator Limón. And with that, we will hand it over to Punita Khanna, who has personally benefited from biomarker testing and biomarker-driven treatments as a patient. She's also an ACS CAN volunteer. And Punita, we'd love to hear more about your story.
Thank you, Hilary, and good morning, everyone. and I appreciate the opportunity to share my biomarker story with you. I'm a breast cancer survivor, a patient advocate, and honored to be a legislative ambassador with American Cancer Society's Cancer Action Network. And I might be familiar to some of you because this past April, I participated in ACS's Cancer Action Day at the Capitol and met several lawmakers and their staffs. And we were there to advocate lawmakers to pass healthcare bills, and I had the opportunity to share my story with some of you. So this story started about 7 years ago on Saturday, March 5th, 2016, 8:15 a.m. And when my phone rang that early on a Saturday morning, I recognized the number as being that of my physician's. And I was quite impressed, thinking, wow, she's working early on a Saturday morning. And as I answered the phone, there was absolutely nothing that was registering in my head about why she may be calling. You see, the events of the previous several weeks had not made an impact on me. 2 months earlier, I'd met with my primary care physician, and we discussed that it was time for me to schedule my annual mammogram. And I thought, well, do I really need to keep getting them? And at that time, I had about 10 years of clear mammograms, so I thought I was good. And offhandedly, I asked her, do you still get one? And she replied, I get one every year. A few weeks after that appointment, I was with my OBGYN, and the subject of scheduling my annual mammogram came up again. And I asked her the same question, do you still get one? And she too replied, I get one every year. I remember those conversations vividly because the reason I had questioned both physicians was because I knew they were around my age. And then I figured, well, if they were still getting mammograms, then I should be bothered to get another one also. So during the subsequent weeks, I got a mammogram, which I was told showed something suspicious, which they wanted to further investigate. And this was followed by an MRI and a biopsy. And even during continued testing, I remained unconcerned. Obviously, I never read the memo, which says that your physician only calls you if the news isn't good. So of course, when I answered her call that Saturday morning, I was thinking, oh, how nice. She's calling me to tell me that everything is fine. She got directly to the point, that my biopsy revealed that my tumor was malignant and I had breast cancer. My head started spinning and my life changed forever. At the first meeting with my surgeon, she mentioned the standard form of treatment, surgery, chemotherapy, followed by radiation. But then she stated that biomarker testing was available that would provide information on whether chemotherapy would be beneficial for me. Immediately, my ears perked up because who wouldn't want to forego chemotherapy if it did not provide any benefit? This biomarker test was the Oncotype DX breast recurrence score test, which was proven both to predict whether a patient would benefit from chemotherapy after surgery, as well as the risk of their cancer returning. It's a genomic test for patients recently diagnosed with early stage invasive breast cancer. The biomarker test would look at the specific gene mutations in my tumor and provide information that would help determine the best treatment plan for me. The process was fairly straightforward. There was nothing I needed to do. A tissue sample from the tumor that would be removed during the surgery would be sent into the lab for testing. And this did not require any additional procedures or any additional discomfort for me. I would receive a numerical score, and based on that score, my oncologist would make a recommendation on a more informed, personalized treatment plan for me. It also meant that I could have a say in my treatment. Before I could agree to the biomarker testing, my surgeon shared one caveat, that the test was not covered by my insurance plan, which meant that I would have to pay for it out of pocket. At that time, the test was between $500 to $1,000, which is a huge cost, but fortunately was not a barrier for me. I readily agreed to pay for the test. Given my own history of ailments, I knew that the less invasive and the less aggressive therapies I needed would be better for my body. My recurrence score result indicated that the likelihood of my benefiting from chemotherapy would be low. I was greatly relieved. My oncologist and I made the joint decision that chemotherapy would be removed from my treatment plan. And knowing the results of the biomarker test gave me a say in this treatment plan. So the huge cost of having a cancer diagnosis is itself a combination of emotional, physical, psychosocial, and financial stresses. One may also experience side effects from chemotherapy, radiation, and oral medications. And then you may have to take additional medications to offset some of those side effects from the treatments and therapies. Everything takes a toll on your body. As a result of my low score through the biomarker testing, my personalized treatment plan became radiation and oral hormone therapy. But I experienced side effects from the radiation, and I suffered excruciating bone and joint pain, as well as leg cramps from the oral medications. Just imagine your head being tightly squeezed in a vice every minute of the day. That's how it was for me for years. You're also at an increased risk of broken bones and osteoporosis, so you're getting infusions to offset this. And the infusions themselves have side effects. The list goes on. After 5 years of suffering from taking oral hormone therapy, my oncologist offered another biomarker test, the breast cancer index test. This test predicts the risk of early stage hormone receptive positive breast cancer coming back 5 to 10 years after diagnosis. Its purpose is to help women and their doctors decide if extending hormonal therapy would be beneficial. The breast cancer index reports two results: how likely the cancer is to come back 5 to 10 years after diagnosis, and if a woman is likely to benefit from taking hormonal therapy for a total of 10 years. Getting this test done was a similar process to the initial biomarker test I had taken, the Oncotype DX recurrence score test. There was nothing I needed to do. A sample of my tissue would be sent to the lab for testing. So once again, I was elated at having another biomarker test available to help personalize my treatment plan. Stopping hormonal therapy altogether was a heavenly thought to me. However, as with the previous biomarker test, this biomarker test was also not covered by my insurance. The cost was about $1,000, which is a huge expense, but fortunately was not a barrier for me. And as before, I elected to have the test done and pay for it out of pocket. My test result number indicated that extending the hormonal therapy for another 5 years would not be beneficial for the type of cancer diagnosis I had. In both cases, where biomarker testing was used to customize my treatment plan, I felt empowered that I had an active voice in my treatment, which was a result of evidence-based science and personalized to my specific cancer criteria. So while my preference would have been that I not be here today discussing my breast cancer experience, because this chapter is one that I would have happily omitted, the story is now a part of my life. I am truly grateful for my medical team in their expertise in recommending the most advanced scientific testing and the least invasive treatments in formalizing a personalized treatment plan. So I've benefited from biomarker testing at 2 different times in my cancer journey, once at the beginning and the second after 5 years. And both times, biomarker testing helped determine the appropriate treatments for me. making a huge impact on the quality of my life. I was able to forego chemotherapy, which has its own side effects, and I did not have to extend oral hormone therapy. And so far, the results of my biomarker testing have been proven correct. It's been 7 years, and I have had no recurrence of cancer. I was fortunate that paying for these tests was not a barrier for me. By my paying a couple of thousands of dollars upfront, the healthcare system reduced its potential cost by tens of thousands of dollars in unnecessary treatment and therapies. I'm sharing my story in the hope that everyone is given the same access to advancements in science so that they too can benefit from improved testing, therapeutics, and treatment, resulting in better outcomes, better quality of life, and lower healthcare costs. Thank you. And now we go back to Hilary.
Great. Thank you so much, Punita. We are so grateful that you are here today and able to share your story to help illustrate the importance of this issue. It's so frustrating to hear that you had to pay out of pocket for 2 different tests that allowed you to avoid treatment that would not have been helpful to you. So really great example of the importance of this testing. Before we get to Q&A, I want to introduce our final speaker, Dr. Wesley Mizutani, a rheumatologist and member of the Alliance for Patient Access, to talk about the value of biomarker testing in his practice treating patients with arthritis. So a little different from the cancer applications that we're so used to hearing about. So with that, Dr. Mizutani, the floor is yours.
Thank you, Hilary. Welcome, good morning. I am the only person on the panel so far that's going to talk about biomarkers in a non-oncologic space. I would like to reference Punita, though. I do call patients even though the tests are normal, so some of us do. Next slide, please. Am I supposed to? Okay. So I'm a rheumatologist practicing in Southern California, and I'm also involved with the AFPA as the board of directors, just as a way of introduction. Recently, precision medical therapy has seen an exponential growth, as you've heard from all the previous speakers. And although the advances in oncology are widely known, those in other medical specialties are less recognized. In the rheumatology space, such precision therapy has existed for over 25 years, improving the lives of millions of arthritis sufferers. It's almost though in rheumatology space that the cart became before the horse, meaning that we have the medicines that are precision in terms of the way they're directed at certain immunomodulators, certain, if you will, immune hormones or receptors to prevent the progression of certain arthritic diseases like rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis, etc. However, the biomarker space has not been present until just recently, and in rheumatology, but it is changing, and the landscape is rapidly changing as we speak. And then such advances will allow us, much like Punita described in oncology, will allow us to use our biologics that we have developed over the last 25 years in the patients, and individualize them to individual patients so that a patient will get the right medicine at the right time, as Dr. Garraway had mentioned earlier. Next slide, please. A little bit of background in rheumatology in terms of the medications. Prior to the turn of the century, rheumatologists' drug arsenal consisted of non-specific immunosuppressants, methotrexate, gold, plaquenil, Immuron are just examples. Much like Dr. Garraway had mentioned earlier, those medicines are really kind of the immunosuppressants, but they suppress everything. So obviously the side effects are greater. And for the most part, many of those medicines have taken a back seat to the biologics that we use now. After the turn of the century, etanercept received FDA approval, otherwise known as Enbrel, as the first precision medication in the rheumatology space. It was directed specifically at something called a tumor necrosis factor, which is a hormone which is very important and crucial in rheumatoid arthritis development. Since there has been an explosion of such biologic treatments. However, the conundrum is which biologic therapy is best for a given patient. The lack of biomarkers in our space has led to a one-size-fits-all approach, meaning that most clinical rheumatologists will use their own clinical experience to determine which biologic will be best for a particular patient without really knowing whether that is really the best one to use or not. Next slide, please. Although clearly in its infancy compared to oncology, there is at least one biomarker that has come to market and many to come on the horizon. Such therapeutic biomarkers will allow rheumatologists to select the best biologic therapy for an individual patient. However, rheumatologists, similar to oncology, needs to have access to these tools to allow the right patient to get the right medication and at the right time. I've already personally seen denials for the sole biomarker in rheumatology. And what happened was that not only prevented the patient from getting the right medication, but also dictated that he receive a medication which was not going to work. And so hopefully with the acceptance of biomarkers by health plans, this will not happen in the future. Next slide, please. So biomarker legislation is imperative not only in the oncologic space, but in all medical and surgical specialties. For example, in the neurology space and the endocrine diabetes space, biomarkers are also becoming important. Historically, California biomarker legislation has solely included the oncology space. These bills, as Senator Limón had pointed out, were specific to stage 3 and stage 4 metastatic cancer patients. As you've seen, biomarker testing is present and being used in other non-oncologic specialties. Legislative efforts across the country now attempts to not only assure open access to biomarkers, but does not serve as a limiting factor for future innovation. To date, more than 10 states have passed legislation ensuring a broader access to the biomarker testing when clinically and medically appropriate. Next slide, please. So we ask for your support of Dr. Limón's bill, SB 496. The value of biomarkers in precision medicine cannot and should not be underestimated. Not only will each individual patient receive the best medicine for them, but also with less side effects and also at the right time. Patients will get better faster because they are started on the right medication earlier. Finally, SB 496 will ensure that all patients, regardless of their economic or their social status, will receive all medicines that are necessary and will have the opportunity to benefit from such precision medicine. I'd like to thank you for your attention. And
Great. Thank you so much, Dr. Mizutani. It's really exciting to hear about the applications outside of cancer. And I know there's so much exciting research happening. I think about 2 weeks ago, the FDA approved a biomarker test for use in women with preeclampsia. And that test allows providers to identify women who don't need to be hospitalized for weeks ahead of delivery because they're at lower risk for complications from preeclampsia. So it's really exciting to see the applications of biomarker testing expand far beyond oncology. There's also current applications in organ transplant and rare disease. So it's really exciting and important that patients are able to benefit from this testing so that this research doesn't stay bottled up in the lab, that there are breakthrough treatments available, that all patients should benefit regardless of their individual circumstances. So we've got plenty of time for questions. I encourage everyone to put those into the chat. The event is being recorded and that recording will be available. So I know someone was a little bit late and we got a question about that. So not to worry. And with that, I would like to start with a question for Dr. Garraway. Can you tell us a little bit about what happens when patients don't get the testing they need? If that's something that you or your colleagues run into, and how does that impact their treatment, and how does that impact their outcomes?
Yeah, well, I think the most important thing that happens when patients do not get the testing that they need is that we just don't, it's a missed opportunity. We don't know what we don't know, right? So of course they'll be placed on standardized protocols that are not really specific to that tumor. But it could be transformative if that tumor has a particular alteration that can be treated with a precision oncology medication in terms of, again, life prolonging therapies that could really make a difference and outperform the more standardized regimens. So again, it's that, that potential lost opportunity to provide somebody with, life-saving treatment.
That's great. And Punita's story is great for showing, avoiding treatment that's unnecessary or ineffective, but we also, hear a lot about the targeted treatments that are available. Could you say anything about kind of the frequency or the number of targeted treatments that are available for different cancer types and kind of how that is changing the landscape? Sorry, Dr. Garraway.
Oh, yes, sure. So, I mean, there's general kind of broad categories of the types of precision treatments that are available. I think the first broad category covers genetic alterations that impact repair of DNA damage. So, the DNA is that integral component of all our cells that tells our cells what to do and how to behave. And sometimes that DNA can be damaged. And if the DNA accumulates a lot of mutations, then that can lead to cancer. And so it's really important so we have medications now that can target particular cancers that have defective DNA damage or DNA repair mechanisms, and that leads to them being more susceptible to that very precise medical oncology treatment. There are other alterations that make tumors more susceptible to certain types of immunotherapies. So that's also another approach. And so the only way, again, we'll know that is if we test the tumor to see if they have these specific alterations that could render them susceptible either to a DNA damaging type of medication or an immunotherapy type of medication.
Great, thank you so much. We have a question about reimbursement of individual marker tests versus panel tests, or some plans, only reimbursing part of a test. First, maybe Dr. Garraway, again, sorry to keep you in the hot seat, if you could just say a little bit more about kind of the difference between single marker tests versus panel tests and kind of what comprehensive testing looks for.
Right, sure. So essentially, when you're talking specifically about molecular testing, so usually that is referring to sequencing of DNA, again, like we were just talking about, how you can look for alterations in those genes. So there are different approaches to how you can do it. You can either have a really broad approach where you sequence every single bit of the DNA, essentially. It's called whole genome sequencing. Or you can go all the way down to just looking at very specific genes that are known to be altered in cancer. So that's kind of a panel-based test. And you can even go down just to looking at a very specific, just one gene only, if you have a high suspicion that like this could be the one that's altered that could lead to a different treatment right away. So the cost of the test is dependent on how extensive and how broad you are doing the testing. And so definitely, the panel tests are more cost effective than an entire sequencing approach. And then, a more specific marker test is probably the most cost effective. But in general, it's really important to, what type of test somebody needs is really dependent on what type of cancer they have, what clinical stage they're in. So it's really kind of up to the doctor and kind of the guidelines that monitor that cancer to dictate what type of testing is most effective in terms of making sure that we identify the appropriate alterations and figure out the next step in precision medicine treatments for that patient.
Absolutely. And, the legislation ties to nationally recognized clinical practice guidelines, NCCN guidelines and ASCO are very commonly used in oncology, and there are similar guidelines for other disease types. But, often, although those single marker tests are cheaper, the panel test can provide kind of more effective information or more actionable information. Some patients might actually have to go through extra biopsies or extra surgeries to get more tissue to run many single marker tests instead of doing a single panel test. So the legislation kind of aligns the coverage for testing among insurance plans with those clinical practice guidelines and other sources of medical and scientific evidence, and also specifies that coverage should limit the need for multiple biopsies and inefficient care in that way. So that's important. Anyone else have anything to add on kind of single marker versus panel testing? Dr. Mizutani, no, you mentioned there's one biomarker in arthritis treatment that you're using right now. So,
well, I think one of the things that plays a role, at least in our space, is that, like, the one biomarker that is available is a test to determine if patients won't respond to a class of TNF inhibitors, which are like all the ones that you see on TV. Those are mostly TNF inhibitors. And what happens is with that class is that most of they've been around the longest. So obviously they're a little bit less expensive. And because of incentives and other things to health plans like them because they get a lot of rebates from them and so forth and so on. So that makes them cheaper. So they're pretty much the first line of therapy if you're going to use a biologic, right? So, but this test actually shows that if you have a positive test, that means you'll respond. If you have a negative test, you won't respond. So there's no point in putting patients on all those things that you see on the commercials, on the ads, because they won't respond. And yet they're the one class that the health plans are the first on their step therapy. And so, and so there's obvious reasons why they're not going to be in favor of this kind of biomarker testing, because that would just make their expense ratio go up, because they're not going to be able to use the ones that they get the best deals for. And I think that's something that we need to be aware of also, that there's a cost driver here too in some cases. But the patient needs to get the right medicine, and like Dr. Garraway said, at the right time. Because if you delay treatment, right, because they didn't get the biomarker testing, then whether it's oncology, which is obviously their cancer is going to get a whole lot worse. In rheumatology, the joints are going to just get destroyed right in front of your face, right in front of your eyes, and that's not good.
Absolutely. I think, cost is often a big concern when we talk about biomarker testing, but there are quite a few studies showing that spending more upfront on more comprehensive testing can actually reduce overall treatment costs for some patients. And Punita's story is a great example of avoiding treatment that's not going to provide any benefit and is often just making patients miserable, right? So there's no upside to that. We have another question about, clearly from all of our fantastic speakers, this is a really important legislation. A no-brainer is how this question described it. What can we do to support this bill and make sure it gets passed? That's a great question. And stories like Punita's are so important, as well as expertise of physicians and other healthcare providers. Punita, can you talk a little bit about kind of your experience, going to Sacramento and talking to lawmakers about this issue, and kind of how that's received, and what you would recommend for maybe people new to advocacy or wanting to get involved?
Sure. Well, it was actually quite an interesting experience. I have never been involved in the political process or the legislative, so it was an educational journey for me. And as I shared my story with the various lawmakers and their staffs, there was understanding. I mean, it's a very simple story. It's just get tested. I mean, if you ask the question, who here would want to have chemotherapy if it didn't provide a benefit? And that would have been the case in that was the situation in my case. And then again, fortunately for the biomarker testing, it indicated that it would not be beneficial. And so I think, when you present it in real terms, as I was able to, and I was able to answer questions, speaking with staff and lawmakers, there would seem to be a great deal of understanding about what exactly this meant for the individual patient. And I think that's what we need to look for. So I would encourage people to tell their stories because, as you said, in my case, it was used to avoid treatment. And again, I mentioned a little bit of my struggle, even with the treatments that I had, the side effects. And I just can't even imagine if I had had to go through chemotherapy, what those side effects would have been, and then managing that and then extending the hormonal therapy for me for 10 years. I mean, I'm still suffering a couple years out. So I think that's, the realism is what is important for everybody to share and for people to understand that this affects real people. And we need to get behind it because we've always been behind advanced scientific testing and evidence-based medicine. And this is a clear case of practicing medicine using evidence-based science.
Dr. Garraway or Dr. Mizutani, anything you'd like to add on kind of getting
Yeah.
involved in advocacy in this issue?
Well, I mean, I think what Punita just said is just so important that we really have to keep at the forefront. I mean, as Dr. Mizutani mentioned, there are so many other competing interests in whether or not to do the test or not, especially coming from insurance companies or other people with different interests than necessarily the patient-centered type interests. But I mean, that preserving that quality of life is so important. And we use biomarker testing in prostate cancer sometimes to make similar decisions to what Punita was faced with, which is how long for a hormonal type therapy. And changing that chemical milieu of hormones really does change the quality of people's lives oftentimes. So being spared, months or years of that therapy, it just makes such an important difference in the quality of that person's life and their ability to interact and engage with others and their families. So it is really important to acknowledge that saving those unnecessary treatments or the lengths of some of those treatments is so important, and that will ultimately also reduce costs in the long run as well.
Yeah, a couple comments. I don't want to do advocacy 101 today because we don't have enough time for that. But just to let everybody know that's on the call, your voice is important, okay? Your state senator or your state assembly person that is in your district, they listen to you. You're their constituent. So your voice makes a big difference. You may not think it does, but your vote makes a big difference to them. So if you talk to them or talk to their legislative assistants and tell them what you think, they will think that it's important because you're their constituent and that's what's important to them. So don't think that your voice doesn't matter. It does. Okay. So I would encourage, all of you, if you want to support this bill, to write a letter, call, do, email, whatever you want, but contact your state senators, state legislators, state assembly person, and let them know how you feel about it.
That's great. And I will note, as Senator Limón shared, this legislation did pass the legislature last year. The challenge was with the governor's office. So there's, again, similar opportunity there to educate and elevate your voices as constituents that this is a really important issue and that there are significant gaps in coverage that are harming patient access to appropriate biomarker testing. And of course, continue to make the case for legislative action, though the legislature has done their part last year and they're doing their part again this year. So we will continue until there is access that patients need. I would also make a plug for folks who want to get involved and learn more to visit fightcancer.org/CA to get involved with ACS CAN in California. We make it easy for you to contact your lawmakers and make your voice heard and share your story. So with that, I think we've gotten through all the questions. I really want to thank all of our speakers for sharing their expertise. This has been so helpful. Oops, sorry. Let me check my other screen. Oh, I apologize. We do have more questions. Too many tabs open. Let's see, I will, I think, give this one to Dr. Garraway to start. Biomarker testing is very valuable once the key players have been identified or molecular characterization of that cancer type has been done. What about not well studied cancers, rare cancers, pediatric brain tumors? That's a great question.
Yeah, it's a really great, really important question. And certainly it's an area of research that needs continued study. And not only for, rare cancers, but, also, across, again, we talked about the disparities across racial and ethnic ancestries. So it's true. We need to understand better what alterations are affecting different ancestries as well. So we can know which ones are variants that really are pathogenic versus a lot of times we just don't know. Somebody will have an alteration in an important gene, but we just don't know if it's actually really kind of what we call pathogenic or going to lead, be able to be matched with a targeted therapy. So these are really important, and we do need to cover all these areas, and it is an active area of research investigation. So hopefully that is the dream one day, to really understand the alterations and exactly what tumors they're impacting, so that we can, again, going back to our common phrase, treat the right patient at the right time.
Yeah, absolutely. It's really exciting to see how similar treatments can work on cancer that shows up in different body parts. So even if something is a rarer cancer or there's not as much research happening, someone might still be eligible for a clinical trial based on their biomarkers, or eligible to try a targeted therapy that's for that biomarker and not necessarily for the body part where that cancer was found, which is historically the approach to cancer treatment. So really exciting for rare cancers, but also really important for the diagnosis of rare disease. I think the stat is it takes an average of 8 or 11 years to get an accurate diagnosis for rare diseases. And biomarker testing can really speed that up and avoid some of the kind of permanent damage that Dr. Mizutani was talking about in arthritis as well, with degenerative diseases. That time spent trying out different treatments or trying to find that most accurate diagnosis can be really detrimental to patients and potentially have huge costs. And the last question was just a reminder of the URL that I mentioned for folks who want to get involved with this campaign and other issues in California. It's fightcancer.org/CA. And I want to again thank our fantastic speakers, and thank you all for joining. The recording will be shared, and we hope you enjoy the rest of your day. Thank you so much.